I'm Dr. Kewal Krishan. I'm Director for Heart Transplant, Ventricular Assist Device and ECMO program at Max Hospital, Saket. And today I'm asked by the Avatar team to speak on the role of ECMO in COVID-19. I'm really grateful to the entire team and very cooperative and helping us to deliver the message what ECMO does during the COVID-19 time. And it has really helped a lot of patients during COVID time and saved many lives. So today I'm going to speak on role of ECMO in COVID-19, our Indian experience. So ECMO is basically a technique of extracorporeal life support which uses heart-lung bypass techniques for days or weeks to support the heart-lung or both the functions in the intensive care unit. The ECMO was started a very primitive state in 51 when it was a bypass machine, and with time miniaturization of the circuit started happening, and we have reached to a stage when the circuit has become a very small. The ECMO was actually started in 70s, and then up to 19 results were not good because of the circuits were very cumbersome. It was difficult to handle. So since 2004, again, the ECMO came with a smaller circuit and with a lot of good functions and less blood damage. So it has given really good results. And since then, it's been very famous and it's being actually used to save many lives. ECMO means extracorporeal membrane oxygenation. It is instituted for the management of life-threatening pulmonary or cardiac failure when no other form of treatment has been or likely to be successful. It is used as a temporary support, usually awaiting recovery of the organs. ECMO is essentially a modification of cardiopulmonary bypass circuit, which is used routinely in the cardiac surgery. So a lot of surgeons and physicians know about IABP. IABP supports only 15% of the cardiac output. Tandem Heart and Impella, they support 30 to 60% of the cardiac output. Levitronix, HeartMate 2-3 hardware, those are permanent devices. They support 100% circulatory support, but for the lungs, you need ECMO. So ECMO support both heart and lungs. That's the only device available to support heart and lungs. So what we usually keep is in the operation theater, everything is ready with the heart lung machine. It's a kind of one pump of the heart lung machine, and everything is primed multiple times when the frequency is more. So the basic indications are either cardiac failure or respiratory failure, or cardiac and respiratory failure both. So indication to use for the cardiac is bridge the patient to end stage heart failure. When the patient comes in code blue, the coronary bypass grafting or valve replacement is being done and the patient cannot come off bypass post cardiotomy, or primary graft failure post heart transplant. So anything where the heart cannot function or deliver the circulatory support which body requires, you can replace from the outside with this artificial machine. So the other indication is when the patient is in the cath lab and you can't. It's a very sick kind of patient and multiple coronary lesions. You need to do a PTCA, and the patient becomes likely that patient become unstable. So you put the patient on ECMO, do the PTCA, and then come out of that, and then you can remove the ECMO. This is another indication. For the lungs, it's a septic shock syndrome or influenza H1N1 or thoracic trauma or ARDS, whether it's bacterial, viral, or fungal. So the ECMO used to be used for all these things, but now COVID-19 has made a really important role in ECMO because the most common organ affected by COVID-19 is lungs. So when the patient is on 2 liters of oxygen, then goes to 10 liters of oxygen, 50 liters, then the patient goes on BiPAP, and then goes on ventilator. But in all these things, your lungs, they work to support the oxygenation of the body. But when your lungs are completely damaged, they cannot support even on the high support of ventilator, then role of ECMO comes, because now you have to give oxygen from another ways. That's the ARDS. It's called as the adult respiratory distress syndrome, or bridge to lung transplantation, or primary graft failure, severe pneumonia, sepsis. And it is basically used for reversible causes. It's not that it's a COPD patients and severe COPD and that will recover. The ECMO is used for the reversible diseases basically. And when the patient is referred to us, most of the time the X-ray looks like a white. It's on ventilator. And sometimes in COVID-19, the X-ray looks like a little better, but the lungs cannot work because of the. And this is how the CT scan looks like of a COVID-19 patient. That the lungs are completely bad, and you cannot oxygenate such kind of patient, and then you put the patient on ECMO to bring the oxygen, because the another advantage is, if you put the patient on ECMO, your lung ventilator settings are low, so your lungs are going to take rest. At the same time, your oxygen is being given to the other organs to survive the organ. This is how the COVID-19 lesions, they look like in the X-ray. So there are two kind of configuration to put the patient on ECMO. One is veno-venous, is purely to help the lungs. Veno-arterial, it helps the lung as well as the heart. So if your heart is also damaged along with that, or heart function is poor, then you can put the patient on VA ECMO also. So this is how the veno-venous circuit is. We put one cannula in the groin and one in the neck, take out 5 liters of blood and put back, oxygenate and put back into the body. So this is how, whether your lungs are working or not, it helps the oxygenation of the body. And the another thing is the Avalon cannula. You can put it in from the neck only, and there are 3 ports, and they do the same function as the lung. You take out blood from the SVC and IVC and put back into the tricuspid valve. So with this, patient can be mobilized also. The another configuration is veno-arterial. I mentioned to you, one in the femoral artery and one in the femoral vein. So blood is coming out of the femoral vein, 5 liters, and put it back. This will not only help the lungs, it will also help the heart also, heart function also. And this is how it looks like on the bedside of the patient. And this is how the X-ray looks like of the patient. One is arterial, small is arterial cannula, and large is a venous cannula. You can do it to the neck also, but the problem is, if you do puncture the carotid, the chances of strokes are there. So people don't use nowadays this technique. As soon as you put the patient on ECMO, your saturation from 70s, 80s, or 60s, whatever it is within a minute or two, it comes to 96, 98. Your heart rates get stable, your inotropes, they go down, your blood pressure gets stable. So all these functions which are being done were compromised, they all get better, and patient's recovery starts getting better. This is how the pump looks like on the bedside. And this is the another pump is Centrimag, which is a similar pump of like Mackey, which I showed you. And both they have the similar kind of function, and they do the function of oxygenation as well as support the heart. It can be used as a bridge to recovery, or as a bridge to decision whether you can save this patient, or as a bridge to another device, or as a bridge to heart transplant, or as a bridge to lung transplant. The insertion of ECMO is usually done with the we give because we put a cannulas into this, so we need to give a heparin, 5,000 to 10,000 depending upon the body surface area. That the ACT should be more than 400 at the time of cannulation, and usually to 200 after that. So this is how we are putting the cannulas into this, and sometimes we use T to take help. This is the configuration of veno-venous. One cannula is in the groin and another is in the neck. And when the X-ray becomes better, we usually remove the ECMO, and it usually takes 13 to 19, 20 days with most of the patient. But in COVID, it took even longer time. So ECMO management is similar as in any ICU patient. With oxygenation, we keep 85 to 100%, the CO2 35 to 40%, MAP of 60, all the normal what we usually do in the ICU for ICU patient. And once the patient starts improving radiographic appearance, they start improving pulmonary compliance, we keep going down on the saturation. And once we find that the patient can afford to separate the ECMO, we usually remove the ECMO, and patient comes in the couch, because these patients are on ventilator before 5-6 days putting the ECMO. And after that, we know that they are going to be on ECMO for like 13-15 days. So we usually do tracheostomy in these patients, most of the patients. And the patient is in the couch after removal of the ECMO. And once we remove the ventilator, the patient is on TPs off, and then we remove it and we mobilize the patient. In this COVID times, we had a lot of patients on ECMO, and this patient, after 75 days on ECMO and 98 days in ICU, the patient recovered. This is the longest survival in the country, our India, so far, this ECMO. We use cytosob also. The cytosob, because these patients, they develop inflammatory reaction, and the outside source also with the ECMO, or the patient has infection or the other things, the cytokines release, and body has to fight for the foreign body or the infections. Then we use the cytosol during the ECMO to stop the fire, because body has to respond. Like if any infection, we get fever. So if the fever continues for many days, the patient's going to get exhausted. So to prevent all these preoperative, during on ECMO or post ECMO period, we usually use cytosob to remove all the cytokines to make the things better, and patient looks okay. This is my paper on in the Indian Journal for the use of cytosob, how it helps with a lot of patients. So decision is more important than the incision you putting the patient on ECMO. So ECMO is basically a rescue therapy and meant to be put on a dying patient. Like the patient is going down. It's not that blood pressure is 40 to 60 and lactate is 18, and then you're putting the patient on ECMO and expecting the patient is going to recover. So the key to success of taking out the patient out of ECMO is maybe the time of initiation, when the patient is drifting down, not that the patient is almost dead and going to die in next 2-3 hours. So we have a retrieval facility also. We bring the patient from another cities also, and we bring the patient from another countries also. We have brought the patient from Middle East, from Nepal and other surrounding countries. Our team goes over there, put the patient on ECMO, and bring the patient to our center. This is how we have brought the patient looks like, and this is in the ambulance, and 5 liters of blood going out of the body and coming back is and taking the patient, bringing the patient with that's a real challenge. You need a very competent team. So this key to success is selection of the right patient indication, initiation at the right time, and utilization the right disposables, and regular practice. So for more information, you can on the ECMO or heart transplant or LVAD, you can go to my website kewalkrishan.com, and you can follow me on the social medias also. I am really grateful to Avatar team to giving me opportunity to speak on this and letting you know how the ECMO helped during the COVID-19 periods. We had almost 10 to 13 ECMOs going on at one point of time during COVID, and I used to receive 150 to 200 calls every day for the need of ECMO. Thank you very much for listening to me, and if you have any questions, I'm more than happy to answer those. Thank you.